Hi, everyone. We're going to give it a minute so folks can join us. Hi, everyone. We're just going to give it another 30 seconds. Okay. Well, I'm Jenny LeRae, and I'd like to thank you for joining Research America on Zoom today. And also for those of you who work for organizations that are members of our alliance, we thank you for your partnership. And of course, if you're not a member, we would like you to be. So please contact my colleague Joel, our director of membership, and his email will be in the chat. So today, I am so excited for this conversation. This is an issue that I've personally worked on over my career in DC. We're joined by Katie Schubert, President and CEO of the Society for Women's Health Research, and Lori Frank, President of Women's Health Access Matters. Katie and Lori and I are going to discuss the gender gap in research and recent actions by the Biden administration and Congress to close this gap. And of course, we'll be focusing on the role of advocates in making this happen. So as always, please type your questions in the Q&A box or the chat, and we will get to them after I've asked some questions as well. So thank you so much for joining us today, Katie and Lori. Great to see you both. So to start us off, some 30 years ago, actually, I think it was 30 years ago this past summer, the groundbreaking NIH Revitalization Act required women to be included in clinical trials equally. And the NIH Office of Women's Health was also established. So it was really a watershed moment in women's health research. And the Society for Women's Health Research was a key advocate during this time. Lori's group, WHAM, was not yet born. Katie, why was the NIH Revitalization Act such a milestone for women's health? And could you also comment on where we are in terms of participation in clinical trials vis-a-vis women?
Sure. Well, first of all, thank you, Jenny. I also am really excited about this conversation, and I'm thrilled with the level of interest in this because, I mean, as you know, from working on this topic for so long, we're all women's health research advocates, whether we know or acknowledge that, outright. So yes, it was 30 years ago last summer that the NIH Revitalization Act was signed into law by President Clinton. And it took a bipartisan group of female members of Congress to move the needle forward on this. There had been some action trying to get this done for a few years before that. But I think ultimately at the end of the day, the legislative action was really critical. So it was watershed for a variety of reasons. And I think that people may not necessarily know that it was not until 1993 that women were required to be included in clinical research that is funded through the NIH. Before that, they didn't have to be. Quite frankly, before that, everything that we knew, or most of what we knew, right, is really based on information gleaned from research in men, and at that, white men of a certain size, which is not even today the average person in the United States. So I think this was really critical in getting attention to the issue, getting a better understanding of issues that differently or disproportionately or specifically impact women, and to get more women included in these clinical trials so that we can fully understand what's going on with their health. And it wasn't that long ago, right? I mean, 30 years is not that long ago. And so we've been all continuing to work on this together. And we just saw recently, I think the data from the Office of Research on Women's Health that's tracking sort of how are we doing at this. They had a report that came out recently. It was for the past 2 years because, data in the government is a little lagging for us. But depending on sort of what we're looking at in terms of the actual clinical trials, we're doing a pretty good job of of that inclusion, right? In some trials, it's 50% women. Some trials, it's 60 to 70% women. Others are a little bit lower. Where I would say I'd challenge all of us, and we may be able to get to this later, is that it really is very likely women of a certain age and white women who are more likely to participate in clinical trials. So the diversity side of those clinical trials is really where we need to be looking at, because people alone are not homogenous, right? And so by including women, that's helpful, but we need more diverse representation of all kinds of women to be able to get more information. But we've made a lot of progress. I want to make sure we celebrate it, but there is a long way to go.
Thanks, Katie. Let's talk about which diseases and health conditions disproportionately impact women. Lori, I thought you could tell us about the RAND report, which WHAM released, WHAM Women's Health Access Matters, released really at its outset, at the outset of the group. What did the RAND report find?
Certainly, yeah. Happy to share that information with you. So it was really fascinating for the researchers involved in this. First of all, to take a look at the proportion of the NIH extramural funding portfolio that was devoted to women-focused research. That's where the work began, because we wanted to answer the question, what would the impact be of increasing investment for women's health research in terms of the whole US economy? So starting with that first step to figure out, well, what proportion would need to be the focus of that increased investment, the proportion focused on women. Across the therapeutic areas that we examined, it was 15% or less. So that was our first surprise, to be completely honest. In the case of rheumatoid arthritis, where a set of disorders included in that disproportionately affect women, just 7% of that portfolio was focused on women. Coronary artery disease, less than 5%. So we took the dollar amount that reflected and said, okay, let's double that investment in research and see with innovation what that could mean downstream. And the answers there also surprised us enormously. So we've started with Alzheimer's disease and related disorders and found that if you were to double that investment just at NIH in that particular condition, this would just be an additional $288 million. You could recognize a return of over 220%. So that stood out to us. By the time we got to the coronary artery disease set of analyses, it was just a $20 million additional investment. We get 9,500% return on investment. This is close to $2 billion return to the economy. And then when we did look at rheumatoid arthritis, doubling what was just $6 million of that investment leads to 174,000% return. What does that mean? That means over 10 billion to the US economy. So this is just looking across a couple of conditions within a few therapeutic areas that were selected because they do affect men and women. But just increasing that attention to women within that research portfolio can yield so much back for the economy.
Were those areas chosen? So it was autoimmune disease, heart disease, Alzheimer's, and what was
lung
the fourth?
cancer as well, yeah.
And were those chosen because of their disproportionate impact on women?
So it's a great question. And the short answer is yes and no. Some of those, like the autoimmune therapeutic area, does disproportionately impact women relative to men, but others, no. So we mindfully varied across those conditions, that for which there was a prevalence difference with more women for some, and that for which there was not.
Okay, great. Lori, your screen is flashing. So I'm going to suggest maybe you just turn off the video and come back on and see if that fixes it.
Okay.
It's kind of glitching. Yeah.
Okay.
But we don't want you to go off camera. So now it's stopped. Katie, what, from the Society of Women's Health perspective, how do you look at health conditions and diseases disproportionately impacting women?
Yeah, when you think about issues that disproportionately impact women, we sort of address women's health as a broad bucket, right? And we like to say women's health is everyone's health, and all health is women's health, right? So as you think about this sort of disproportionate and different impact on women, this is really critical. This is why we needed more women included in clinical trials and why we need to look at things like sex differences. So all of the areas that Dr. Frank just mentioned are really critical to us as we think about disproportionate impact. One of the, I would say, more commonly known, although it's still not well known, is cardiovascular disease. When we think about, again, not necessarily disproportionate, but it's still the #1 killer of women. Heart attack symptoms look very different. I think, we've all sat in meetings, and in particular, there was a congressional briefing, just a few months ago where we heard a story of a woman who presented 3 times having an active heart attack in the emergency department and was turned away, right? So that should not be happening, but the reality is clinicians don't necessarily have the tools they need to be able to identify this, and women as patients don't necessarily know that this is what's going on because it presents differently, right, than what you would traditionally think of. So there's that. But I also think when we think about things like Alzheimer's disease, which was a surprise to me coming from the maternal health side of things, 2/3 of Alzheimer's disease patients are women. And so there's clearly a different and disproportionate impact there. And then when you layer on a caregiving aspect, as we do with Alzheimer's disease, most of those caregivers are also women. And so there's sort of all of these different layers and intersectionality related to women's health that we think about when it comes to this. I mean, I'd add, migraine and pain. Lori mentioned autoimmune disease. That is a huge area of disproportionate impact for women. And then I'd put a little plug in for the specific impact on women, just when we think about advocacy and research and dollars in particular, for something like endometriosis, which is getting a lot of press right now. And I think it's amazing that so many people are talking about this because it's really important. We think the sort of proportion of women who have endometriosis is similar to that of the proportion of women who have diabetes. But when you look at the comparison of investment from the NIH in particular, you can't even compare them. It's like, I think we have $22 million at NIH for endometriosis. And of course, diabetes is in billions. I am not suggesting we shift dollars here, right? We're supplementing, not supplanting. But when we think about this from an advocacy perspective, you can see the differences, right, in terms of priorities.
I think, go ahead,
if
Lori.
I could just amplify that point, because with the Alzheimer's disease-related dementia findings, actually, we did see important differences in terms of the cost savings for women versus men. And a lot of that did have to do with the differential trajectories of caregiving, with the majority of women caregivers. And that was even accounting for the fact that, yes, much higher proportion of women with Alzheimer's disease, age 65 plus. And I'll also add that the reasons for that differential in terms of women and men is still not clearly understood. A lot of people chalk it up to differences in life expectancy, and it turns out that no, that's not the answer. So there's still so much that we need to understand about that difference.
Both Katie and Lori, your comments remind me that I really think when we look at women's health research, I see it as there's sort of 3 legs of the stool. So there's diseases and conditions that disproportionately impact women, like autoimmune disease. Then there are conditions that impact women differently, like heart disease. And if we don't know that, then women will be underdiagnosed. And we've seen that. And then there are those conditions that impact women because of our physiology and our biology, like endometriosis. So there are really 3 legs of that stool, and your organizations are addressing all of those. Let's talk about the Biden administration announced some very big plans regarding women's health research. First, big investment at ARPA-H, and then they issued an extensive executive order last month. So let's first talk about the ARPA-H initiative, where does it stand and what can we expect in the coming months? Lori, why don't we start with you on that?
Certainly, yeah. So we're all very excited about what is happening with ARPA-H for a few reasons. One is because of the investment that's been made in funding that Sprint for Women's Health, excuse me. And then another reason why we're so excited is because ARPA-H is just a completely different and innovative model for biomedical research funding. And many groups got together and submitted by the April deadline for ARPA-H for that first Sprint for Women's Health. And ARPA-H is all about accelerating research and translation into clinical care. And so for that reason, people will be hearing over the next few months. They really have a pretty quick turnaround cycle there. So another interesting part of the ARPA-H model is that they're funding both what they call Spark Awards and Launch Awards. They're paying attention to all phases of the research to translation continuum. So we're very excited to see that investment.
That's wonderful. And Katie, let's talk about, and Lori, please jump in as well, but let's talk about the executive order that was released last month, because it has a lot of different components. Can you share with us sort of some broad strokes and what the society is focusing on?
Yeah, it is very huge. I would say extensive, as you said, right? But I think that's because it's the first ever executive order on women's health research, and we have so many gaps to fill. So it is incredible that the administration is taking this seriously, and it's exciting to see. And I think it's so extensive because it crosses all of the federal agencies. So back when the initiative itself was announced in November, the call was really internal. It was asking federal agencies within HHS, but also outside. So it included DOD and VA and EPA even was included, which, you wouldn't necessarily think of if you weren't knowing sort of what the impact is, but obviously environmental health is very important. So they asked for these agencies to report back to them by December 28th, which is the greatest date ever for a federal report to come back, to say, what are you doing in women's health research? And what could you do if we were to scale this up very quickly? So the executive order is built on what those agencies shared. And I should also say, disclosure, I don't know what those agencies shared. That's not publicly available, but I think based on sort of what we've seen come out of the executive order, we can probably take a guess on a few of those things. So, it obviously included a huge portion directed at the NIH. So the NIH is going to integrate and prioritize women's health research across their institutes, to make sure that sort of they have this lens of women's health and sex differences in every institute that they're funding research at. As a part of that effort, what they did is they took earmarked, I guess, in not from a congressional sense of the word, but they took $200 million in new money that has already been included in the FY25 budget for that effort. So we are looking to NIH right now to see sort of what's the list of things they're going to be working on, within what ICs will this go, but that is money that is already being spent alongside that $100 million from the Sprint for Women's Health at ARPA-H. So those things to me are enormous, just because we don't have it's a dedicated effort, right? It's not something that we have to go fight for. But there's some other interesting things in there too, related to FDA better sort of integrating these issues, harmonizing the common rule, which we at SWHR have been calling for a number of years now. The NIH has changed the common rule regulations back in January of 2017, and FDA still has not necessarily done that when it comes to women's health and human subject research. So we're looking closely to make sure they're going to do that as a part of this executive order. There were some really interesting things from CMS in particular that I wanted to make sure to note, because they said, and this is also something we've been asking about for a long time, when you think about coverage and value, particularly when it comes to the Medicare population, because, once you turn 65 and you go into the Medicare system, you don't get treated any differently. You don't seem to have any acknowledged different health care needs if you're a woman or a man, which doesn't seem quite right, that it's just suddenly you turn that age and you go in and you get what you get. So what they said was they're going to have a lens of women's health and women's health needs in their coverage with evidence development work. So that's really critical because they're actually going to be thinking about women as patients, unique needs that might interact with other areas, et cetera. So I feel like that's really exciting. And then there's some issues I mentioned, EPA, they're going to look at women's health in their rulemaking. DOD has a big chunk of this, the VA, all of those agencies. So, but I think for me, that like those key words of integrating and prioritizing women's health across the federal research enterprise is really critical. And it's the first time we've seen that come down from, I mean, that's from the very top. That's the top, the most top that you can get, right? So that's a huge, I think, demand that we're watching really closely to make sure that that happens.
Let's talk a little bit
Yeah,
about the Office of Women's Health Research, which has played at NIH, which has really been, you know, sort of at the center of so much of this. What are they getting additional responsibilities or additional funding through this process? Lori,
So,
can you answer that?
Ray, you go.
well, Katie, please go ahead. Yeah.
Okay.
Okay.
So the Office of Research on Women's Health, and Jenny, you noted that it was codified at the NIH Revitalization Act. It has been around since 1990. They sort of oversee and hold strategy for women's health research across the NIH. So it's really important, and again, critical to that integration piece. ORWH in the president's budget request this year actually got a doubling in their request, which is also huge. For the first time ever, ORWH had a line item just a few years ago, which they didn't have before. Congress also gave them, or confirmed, I guess we should say, grant-making authority for ORWH. And they do partner with all of the ICs to make sure that, you know, they're getting research opportunities out. So that's really critical. But I also think where they're going to, or I hope that they will be engaging, particularly when it comes to the executive order, is accountability. So accountability across the ICs. You know, direct line to the NIH director to make sure that where that 200 million is going is actually where it's going. And there's an important report out. And then on the sex differences research side, to make sure that the implementation of NIH policies are happening. So they're really critical in this. I think, you know, obviously you'll see them leading the way in terms of what this looks like across the NIH.
Thanks, Katie.
Yeah,
Lori, I think you wanted to jump in.
Sure. Yeah, I just wanted to add that the executive order really stood out because of the wide range, as Katie mentioned, of the agencies in the government that have now been identified as helping with this change, this reorientation towards women's health research. And you had mentioned the NIH Revitalization Act, and you know, that WHAM helped commemorate that last June, and Senator Mikulski was able to be there, where she said an anniversary should be a time to rededicate to the purpose. So we were thrilled because with that executive order, because part of what came out of that echoed what emerged from that particular commemoration, where we said it's time to double the budget, going back to the questions you asked about the RAND report. That those were the beginning analyses where we said, what happens if we double that budget? And here we see that all the way to the White House, that has actually been carried through, along with expanding clinical trial access, which we discussed earlier. And then the last thing I'll say is taking a look at data that have already been funded, that's already been paid for. That's the third of our 3 Not 30 goals. We think so much more could be learned. And because of that executive order's view across all of those agencies, there's so much information that is being generated now, but has already been funded. How much more could we learn if people just go back and look at sex and gender?
So I'm so glad you mentioned that, because I wanted to talk about the concept of sex as a biological difference. You know, Senator Mikulski and Congresswoman Lowy who I also worked for, two big women's health proponents, when they would speak to groups, they'd say, well, when we started working on this, even the lab rats were male. Well, it turns out the lab rats are still largely male. Lori, could you talk about the sex as a biological difference, why that's important? I know that the journal Nature announced that it will now specifically ask about how sex and gender are considered in the study design for their publications submissions.
Yes, excellent. And those two items are actually linked. I'm so glad you're asking about this. So sex as a biological variable became a policy related to clinical funding really relatively recently. So we're just going back to 2016 here. And yes, many people weren't even aware that basic research from laboratory animals to humans didn't necessarily have this requirement. I would also add that as more and more organizations are paying attention to sex and gender and other variables, they are reporting on their representation by sex and gender, but not always sharing what the comparisons are. What could we be learning? So it's not just including female animals or women in trials, but it's also learning from that inclusion. And so the Office of Research on Women's Health has some great training materials around that sex as a biological variable policy. I highly recommend it. They can be found on their website that explains really what that's intended to do. And I think that is an important new guideline addition to help move us toward that better evidence base for women's health research. The other part of that is what happens when researchers are thinking up their own studies, setting hypotheses, and then deciding how to analyze those data, and having journals as part of that accountability system to make sure that the whole research ecosystem is not just collecting the information, but learning from it is really, really key. So at WHAM, we have identified the WHAM Accountability Index as including journals, journal editors especially, an important part of ensuring that the culture really does shift so that we can increase what we know about women and women's health.
Really interesting. So that's at both the preclinical and the clinical level, having more of the results shared. Let's talk about intersectionality and how we can make sure that women from underrepresented groups are part of this advancement. Because we know that women of color are not represented equally in clinical trials. What work are both of your organizations doing in that respect? And does this executive order pertain to that? So maybe Katie, we'll start with you.
Yeah, I mean, it does in a variety of ways, but I think the sort of most direct way is in thinking about integrating into diversity of clinical trials plans at FDA, the women's health aspect too. So that's a key part, I think, of the executive order. And in a time when we know that coming out of COVID vaccine trials, that not only were certain subpopulations of women, like pregnant people, not being included in clinical trials when they could and should have been, people of color were treated even worse, right? Like we just have no data related to the treatment population as being actually reflective of, or the trial population being reflective as the treatment population. So that's a key component, right? You have to make sure that you're centering the folks who are actually going to be the end users of this. And that means designing trials that are easily accessible, community-based in many cases. When we think about women and women of color, we have all of these health disparities across the board. It does not matter whether we're talking about maternal health, or uterine fibroids, or heart disease, or menopause symptoms, all of these things, bone health, like there are disparities along racial and ethnic lines that we have to be really aware of. And we need to make sure we're actually centering the people who we want to make sure are included in the trials, that we're actually inviting them to be a part of the clinical trials, right? Like we talk a lot about and think a lot about the mistrust and distrust of the healthcare system and healthcare information in this country. And I know, Research America has done a lot of work on this. It's a critical point to all of the work that's happening now. At the end of the day, many people aren't even asked to be included in clinical trials. So I think that's a really key point. And again, having those trusted messengers to really engage and make these points. So don't assume like somebody doesn't want to participate and we'll just figure out how we're going to get that information. We have to make sure that that's happening. So I would also say too, like there's a lot of legislative action related to diversity in clinical trials. The last thing that I would say is the data pieces are really critical. So ensuring that when we get into sort of the technicalities of trial design and data collection efforts, things like sex and gender, we know are really important. They're not the same things though. You actually need both sex, right? Sex assigned at birth and gender identity, because there's different sort of health influencers for all of these and different risks associated, related to your sex assigned at birth. So you need these, but they cannot be in the same, same data bucket. Just like race or ethnicity are not the same things, and those should not be conflated either. So really thinking about standardized definitions, data collection efforts to make sure that we're getting as much information as possible and it's actually being analyzed.
Thanks, Katie. Lori, is there anything you want to add to that?
Yes, definitely. So our second of our 3 Not 30 goals is all about expanding clinical trial access, and it includes outreach that's required for a part of that process. So we are very much supportive of public-private academic partnerships. And in that regard, we're very interested in what's going on with decentralized clinical trial models, bringing research to communities rather than always requiring that communities travel into academic medical research centers, which does present barriers to different populations by a host of different variables, including age, but also race and ethnicity and geographic reach in terms of rurality and access. So we're really excited about a partnership that includes Walgreens, as retail pharmacy is expanding outreach through decentralized clinical trial models, along with Northwell Health and KPMG, bringing some of those data assets to bear, because technology is part of the answer here for that outreach and the differentiated outreach, including to ensure that women are asked to participate in trials and that there's the appropriate attention to populations that have historically not been included, and therefore our evidence base is just not appropriate. So the outreach here includes to African American women and Latina women especially, but this is just the beginning.
I'm going to ask our team to put, we did a survey on public attitudes towards public opinion around participation in clinical research late last year with ACRO. And I'm going to ask the team to put it in the chat. And one of the findings was that people want, as part of their routine medical care, and certainly those who are being treated for a particular condition, they want to have the opportunity to participate in a clinical trial. They want to know about it, and they want it to be part of their regular health care. So there's a lot of improvement we need to make in that sense. I'm going to invite my colleague Jacqueline Lagoya to join us on the screen, because we have a number of questions from the audience, and we also have a number of questions that were pre-submitted by folks. So Jacqueline?
Yes, thank you, Jenny, and thank you, Lori and Katie. This has been an excellent discussion so far. So our first question from the audience: given the gaps in women's health research, what do you think are research priorities from a health workforce's perspective? And I'll let whoever would like to jump in first.
Yeah, certainly. So I can take that. Health workforce is really key to the quality of clinical care. And there are a few different elements involved in addressing health workforce and its relationship to the quality of care that all people get, but especially attention to women's health. The first has to do with representation. What's the lived experience of the individuals that are providing the care, that are reading the research and interpreting it to help with clinical decision making, and then of course the lived experience of those who are conducting the research and making decisions about it. So awareness, raising awareness for all people of the true disparity with regard to knowledge about women's health is the first step, and then ensuring that you're attracting people who carry this awareness with them into the clinical encounters is really key. But pipelines can start quite early with science training early on for all people. But again, building in that awareness of the disparities that exist and how best to maintain that awareness and overcome some of those barriers to the good clinical care.
Great, thank you, Lori. And Katie, do you have anything to add from your perspective?
I think that's spot on. I think I would add one small thing, which is sort of the education system, right? Not just medical education, of course. I think we know that clinicians get, just a minuscule amount of women's health education in the course of their medical school careers. And if anybody does not know this too, even if you go into OBGYN, you probably don't learn all that much, if anything, about menopause. So just know that there's a lot of work there. But I also think from a research training perspective, right? Like getting training on things like sex differences. So the training modules that are at ORWH that Lori mentioned are really critical. And then thinking about how we can make sure that we're getting that knowledge base right, so that then we don't even have to question sort of what the evidence is based on, because it will already be baked in, if you will, to the system.
Great,
An excellent
thanks so
point.
much.
Yeah, so medical training, I concur, an important area for attention as well.
Excellent points there. So on to our next question. What percentage of Biden's administration's new women's initiatives will be allocated to research? Where, how, and when?
That would be difficult. I think that's going to be difficult to answer. I will just say.
Yeah, although I can say
it's very difficult.
say,
But I mean, I think 100% of it will be dedicated to research because it is specific to research, but sort of what that research is, like, we don't know what the breakdown of like basic or clinical, translational, health services, like there's a lot of different ways for us to sort of slice and dice this. But the how and the when and the what we're still looking at. So that 200 million I mentioned at NIH, we're hoping they'll be able to share with us, because we were reminded that we were not yet in fiscal year 25, and that's when the money will be spent. We're hoping that we will be seeing this list of the exact tangible things, because that's sort of where we come in to be, as a community, all of us, right? All of us here today, to be able to keep pushing it, right? And keep getting more. We want it to be sustainable. That's the key piece here. I'm sorry.
But I would just add that now is part of the answer. So really delighted to see that ARPA-H investment as the first step out. So it's begun.
Great. It's good to know. So on to our next question. There were a lot of participants that asked how their organization can get involved. Someone mentioned May is Women's Health Month. There was one in particular, they were wondering about the vital research that is lacking on women with ADHD, and they're interested in aligning efforts with those of both of your organizations.
Excellent. So I am delighted to hear questions along this line. We do often get asked, how can I support this work? What do I need to do? What can I do to help? So our answer for that is, first of all, raising awareness and really helping to spread this information that we're all collecting about the true disparities, but the impact of those disparities from the economic perspective. It's the business case for investing in women's health. Knowing about that, understanding what work has been done. We talked about the RAND reports as a first step in that direction, but also the costs of inaction and raising awareness about that. What does it mean when women go to an emergency room and their symptoms are not interpreted correctly? We're talking about clinicians who want to help and do the right thing. And what's that barrier to getting that recognition? So what's the increase in awareness that's needed to drive that information forward?
I think this is a really grand opportunity for folks who haven't necessarily traditionally thought of themselves. Like, obviously, both of us are in the women's health space. We have sort of these broad purviews, but we do work in particular conditions or disease states or life stages. And so for any organization that has like a very focused area, number one, just specifically related to sort of like during the month of May, what can we do? Please reach out to us. You know, you can always send me an email or our communications team, which is just communications@swhr.org. We will amplify what you're putting out. We'll give you examples of what we're putting out that you could potentially customize. But also think of it in relation to even outside of May, please. Just in thinking about like, how does this relate back to, how can we tie this into sort of some of the initiatives that are happening? Because the opportunity, I think, for all of these advocacy organizations and research and scientific organizations is that the thought is there will be more here for all of us to do. So we want you all to be following that money and opportunity as well, right? Because that's just going to help us in the end really elevate this topic. But we are happy to partner with anyone and everyone to make sure that we're all, you know, a rising tide lifts all boats, as we say. So making sure that we're all continuing to sort of beat this drum.
And I just want to add to that, Jenny, you had mentioned 3 elements to the definition of women's health, and it has to do with those conditions solely affecting women, disproportionately affecting women, or differently affecting women. I appreciate that question, including ADHD as a great example of a condition that differently affects women in ways that we don't even know. And that goes all the way to access to care and diagnosis. We hear about more and more women being diagnosed much later in life than men. And it's almost a catch-22. We don't even know the full scope of those disorders that differently affect women. So keeping that focus on awareness, but that women's health is broad. It's health that affects everyone. And what do we need to understand about how it affects women differently?
You know,
Thank
Jacqueline, I'm just going to take the moderator's prerogative and make a comment, which is that, you know, it wasn't until there were at least a critical mass of women in Congress that there was any federal attention to women's health. And then, for example, as women started becoming, you know, more equal in numbers in med school, women surgeons started focusing on breast cancer, and they had a huge impact on an increased focus and awareness on breast cancer research. And there are many men who are amazing women's health advocates and have contributed greatly to women's health research. But I think that as women have gone into research, we've seen, you know, greater attention because it's, you know, they're bringing life experience in with them and the experience of those around them. So one of the questions that came in was, you know, what can the academic community do to help support women in research?
Yeah, so I so appreciate your point and that there are men and women. Again, I go back to awareness, because everyone that we talk to about the disparity, the response is, I had no idea. So these are clinicians who want to help and do the right thing. Researchers as well had no idea. Some of it goes back to the historical legacy of how we're all trained, which relates back to the importance of training and pipeline preparation. But I would say that focusing on all people learning and being aware of what the disparity is and being sure to just ask those questions. How might this differ by sex and gender and other variables that are important?
Katie, do you want to jump in there?
Yeah, I mean, I think it's really critical, and I think you're right. And putting on my, ex-Hill staffer hat as well, right? And having worked for female members of Congress, you're absolutely right that the conversation and the action happened when strong women came together and did something about it. And I think we're now at this critical time again, where we have more women members of Congress than we've ever had before. And I won't bemoan the state of sort of politics these days, because that's not something that I will definitely get in trouble for that. But I do think there's a lot of education and awareness that needs to happen, both on the policy side and the advocacy side. So making sure that, again, we're all talking about it. It's baked into the system. We are leveraging passionate people from all sides of the aisle to be able to have this conversation. And that's really, I think, what's going to move the needle forward, because we've made it so far. We need to now level up, right? And that's going to require some big challenges. And I'm not just talking about like getting legislation passed. We're going to probably need that at some point. But even on the funding side, we all know, and I know from just recognizing a lot of folks' names on the attendee list here, right? Like, we're all in this on the appropriation strategy side. And so really thinking about how we can come together in a meaningful way to address this issue is going to be critical. And I think if you're in an organization, I saw one person had said, like, how do I get involved in this, right? Like, run this up the flagpole at your organization and make the case for this being an opportunity. The train is starting to move, right? And we want you all to jump on with us, because that's going to be what I think there will be great success in that for all of us. It being one thing. And then the other piece too is when we think about the executive order in particular, and we think about it being an election year, we don't know what's going to happen in November at all. Like, we just have to be prepared to roll with whatever happens. So getting as much done in terms of standing up infrastructure that's necessary, generating buzz, right? I now see menopause is a hot topic, and that's an intended pun there. But a lot of members of Congress want to talk about menopause now. I will tell you, a year ago, we tried to have conversations about menopause with a lot of different people that we thought would be very interested. And we were sort of told, like, that doesn't sound very exciting. That sounds more like a personal issue. And here we are, a year later, and there are tangible policy goals associated with that. So keep doing it, right, and talking about it. And I think that's going to just help us all.
Well, Katie, those are perfect closing comments. Lori, we are past time, but I want to offer you the same opportunity, just briefly, your closing thoughts.
Certainly, thanks. Yeah, and so I would add that it's not all up to the federal government. We're so excited to see the actions. WHAM, as you know, focuses also on the opportunity in private industry. So private investment is a great opportunity for increasing awareness and increasing the information that can really move some of these life-saving innovations, but certainly innovations that help improve everyone's quality of life, from when it's just a concept all the way through to getting it to market and into the hands of the people that need it. So just as you mentioned, there's 3 pillars to women's health research. I think it's important to remember that there are multiple actors that can come together in partnerships to move the needle and make the progress that we're looking for.
Oh, I think Jenny's video may have frozen. Sorry about that, but I can take over for the moment. I think we were just wrapping up. Thank you all, the audience, for participating, and thank you, Katie and Lori, for joining for this very meaningful and important discussion. I just posted the next Alliance discussion for members only in the chat, so join if you're able, and have a great afternoon. Bye.
Thank you all.
Thank you.